Welcome, future clinicians, to a critical exploration of medical challenges in pregnancy. As you prepare to embark on your medical careers, understanding these conditions is paramount. This session will equip you with the foundational knowledge to identify, manage, and advocate for optimal maternal and fetal health, ensuring every pregnancy journey is as safe as possible. Gestational diabetes mellitus, GDM, is defined as any degree of glucose intolerance with onset or first recognition during pregnancy. This condition, typically emerging in the second or third trimester, affects a significant percentage of pregnancies worldwide. It represents a unique metabolic challenge, demanding careful attention and management. The primary cause of GDM lies in the complex hormonal milieu of pregnancy. Placental hormones like human placental lactogen, HPL, cortisol, progesterone, and estrogen induce a state of insulin resistance in maternal tissues. While a healthy pancreas can compensate by increasing insulin production, in GDM, the beta cells fail to meet this heightened demand, leading to elevated blood glucose levels. The risks associated with GDM are substantial for both mother and baby. For the mother, GDM increases the likelihood of preeclampsia, operative delivery, C-section, and a significantly higher risk of developing type 2 diabetes later in life. This long-term risk underscores the importance of postpartum follow-up. Fetal risks are equally concerning, including macrosomia, large for gestational age, which can lead to birth trauma like shoulder dystocia. Neonatal complications such as hypoglycemia, hyperbilirubinemia, and respiratory distress syndrome are also more prevalent. Furthermore, children born to mothers with GDM have an increased predisposition to childhood obesity and type 2 diabetes. Diagnosis typically involves universal screening with an oral glucose tolerance test, OGTT, between 24 and 28 weeks of gestation. Early screening may be considered for high-risk individuals. Understanding the diagnostic criteria is crucial for timely intervention and preventing adverse outcomes. Management of GDM is multifaceted, beginning with intensive medical nutrition therapy and regular physical activity. Blood glucose monitoring is essential to guide treatment decisions. If lifestyle modifications are insufficient, pharmacological interventions, primarily insulin, are initiated to achieve glycemic control. Oral hypoglycemic agents may also be considered in select cases. As future healthcare providers, your role in GDM management extends beyond prescribing. Patient education on diet, exercise, and self-monitoring is vital. Emphasizing the importance of adherence and long-term follow-up for both mother and child is a cornerstone of public health awareness in this context. Hypertensive disorders represent a leading cause of maternal and perinatal morbidity and mortality globally. This group of conditions encompasses a spectrum, each with distinct diagnostic criteria and management implications. Understanding these distinctions is critical for accurate diagnosis and timely intervention. Gestational hypertension is characterized by new-onset hypertension after 20 weeks of gestation, without proteinuria or other signs of end organ damage. It often resolves postpartum, but requires close monitoring. Preeclampsia is a more severe condition, defined by new-onset hypertension after 20 weeks, accompanied by proteinuria or signs of end organ dysfunction, for example, renal insufficiency, liver involvement, neurological symptoms, hematological complications. Eclampsia is the most severe manifestation, involving the development of new-onset grand mal seizures in a woman with preeclampsia. This is a life-threatening obstetric emergency requiring immediate intervention. Chronic hypertension refers to hypertension present before pregnancy or diagnosed before 20 weeks of gestation. These patients are at higher risk for developing superimposed preeclampsia. The pathophysiology of preeclampsia is complex and not fully understood, but it involves abnormal placentation leading to widespread maternal endothelial dysfunction. This results in vasoconstriction, increased vascular permeability, and activation of the coagulation system. Genetic, immunological, and environmental factors are also thought to play a role. The risks associated with hypertensive disorders are profound. For the mother, complications include placental abruption, stroke, acute kidney injury, pulmonary edema, and HELLP syndrome, hemolysis, elevated liver enzymes, low platelets. Fetal risks include intrauterine growth restriction, IUGR, preterm birth, and stillbirth, often due to uteroplacental insufficiency. Diagnosis relies on accurate blood pressure measurement and assessment for proteinuria and other signs of end organ damage. Regular antenatal screening for blood pressure is paramount. Laboratory tests, including complete blood count, liver function tests, and renal function tests, are crucial for assessing disease severity and progression. Management strategies vary depending on the specific disorder and gestational age. For gestational hypertension and mild preeclampsia, close monitoring of maternal and fetal well-being is key. Antihypertensive medications may be used to control severe hypertension. For severe preeclampsia and eclampsia, delivery is often the definitive treatment, regardless of gestational age, after maternal stabilization. Magnesium sulfate is administered to prevent and treat eclamptic seizures. Public awareness campaigns should emphasize the importance of regular antenatal care and recognizing warning signs like severe headaches, visual disturbances, or sudden swelling. As future physicians, your ability to differentiate these conditions and initiate appropriate management can be life-saving. Anemia, defined as a decreased hemoglobin concentration in the blood, is one of the most common medical complications of pregnancy, affecting a significant proportion of pregnant women globally. It often goes unnoticed due to its insidious onset, making public awareness and routine screening critical. The most prevalent type of anemia in pregnancy is iron deficiency anemia. This occurs due to the increased iron demands of pregnancy, necessary for expanding maternal red blood cell mass and supporting fetal growth. Inadequate dietary iron intake, pre-existing iron deficiency, and multiple pregnancies further exacerbate this risk. Other causes include folate deficiency, vitamin B12 deficiency, and chronic diseases. Symptoms of anemia can be subtle and often overlap with common pregnancy discomforts, such as fatigue, weakness, and shortness of breath. Other signs may include pallor, dizziness, and palpitations. Severe anemia can lead to more pronounced symptoms and complications. The risks associated with anemia are significant for both mother and fetus. Maternal risks include increased susceptibility to infection, postpartum hemorrhage, and impaired physical performance. Severe anemia is linked to an increased risk of cardiac complications. Fetal risks include preterm birth, low birth weight, and impaired neurodevelopment. Anemia also increases the risk of postpartum depression. Diagnosis involves routine screening of hemoglobin and hematocrit levels at the first prenatal visit, and again in the late second or early third trimester. Further investigations, such as serum ferritin, mean corpuscular volume, MCV, and red cell distribution width, RDW, help differentiate the type of anemia. Early detection is key to effective management. Management primarily focuses on iron supplementation, often with ferrous sulfate, to replenish iron stores. Dietary counseling to encourage iron-rich foods, for example, red meat, leafy greens, fortified cereals, is also important. Folic acid supplementation is routinely recommended in pregnancy to prevent neural tube defects and also helps prevent megaloblastic anemia. In severe cases, intravenous iron or blood transfusion may be necessary. As future medical professionals, you must advocate for universal anemia screening and educate pregnant individuals about the importance of iron-rich diets and supplementation. Emphasizing adherence to prescribed iron regimens and dispelling myths about side effects are crucial for improving maternal and fetal outcomes. Urinary tract infections (UTIs) are among the most common bacterial infections encountered during pregnancy. The physiological changes of pregnancy predispose women to UTIs, making them a frequent concern in an obstetric practice. Early recognition and appropriate treatment are essential to prevent serious complications. UTIs in pregnancy can affect different parts of the urinary tract. Asymptomatic bacteriuria, ASB, refers to the presence of bacteria in the urine without symptoms. Cystitis is an infection of the bladder, causing symptoms like dysuria and frequency. Pyelonephritis is a more severe infection involving the kidneys, often presenting with fever, flank pain, and systemic symptoms. The increased susceptibility to UTIs during pregnancy is due to several factors. Hormonal changes, particularly elevated progesterone, cause relaxation of smooth muscle, leading to ureteral dilation and urinary stasis. The growing uterus also compresses the bladder and ureters, further impeding urine flow. These changes create an ideal environment for bacterial growth. Symptoms of cystitis include dysuria, painful urination, urinary frequency, urgency, and suprapubic pain. Pyelonephritis presents with more severe symptoms such as high fever, chills, nausea, vomiting, and flank pain. Asymptomatic bacteriuria, by definition, has no symptoms, highlighting the importance of screening. The risks associated with untreated UTIs in pregnancy are significant. Asymptomatic bacteriuria, if left untreated, can progress to symptomatic cystitis and, more dangerously, to pyelonephritis. Pyelonephritis is associated with an increased risk of preterm labor, low birth weight, and maternal sepsis. It can also lead to maternal renal dysfunction. Diagnosis involves routine urine culture screening for asymptomatic bacteriuria at the first prenatal visit. For symptomatic UTIs, a clean catch midstream urine sample is sent for urinalysis and culture with sensitivity testing. This helps identify the causative organism and guide antibiotic selection. Management involves prompt treatment with antibiotics that are safe in pregnancy. Common choices include penicillins, cephalosporins, and nitrofurantoin. Trimethoprim sulfamethoxazole is generally avoided in the first and third trimesters. Adequate hydration is also crucial. For pyelonephritis, hospitalization and intravenous antibiotics are often required. As future medical practitioners, you will play a vital role in educating pregnant individuals about proper hygiene, adequate fluid intake, and the importance of reporting any urinary symptoms promptly. Emphasizing the necessity of completing the full course of antibiotics, even if symptoms improve, is key to preventing recurrence and complications. As you progress in your medical training, remember that these conditions are not just textbook entries, they represent real patients, real families, and real challenges. Your understanding, vigilance, and compassionate care will directly impact lives. Mastering the nuances of diagnosis, management, and patient education for these common pregnancy complications is fundamental to becoming an effective and empathetic physician. Take action now, deepen your knowledge by reviewing current clinical guidelines for each condition. Engage in discussions with your mentors and peers about complex cases. Advocate for comprehensive prenatal care and patient education in your communities. Your commitment today shapes the health outcomes of tomorrow's mothers and children. Thank you for watching video.